Second thing that I thought was really exciting, as I hear this, is that very often when patients have been screened and don't get the results right away, they go home and they get really anxious, really upset, and very often they don't come back to find out. They don't want to know. And by the way, it's not unique to, the Navajo reservation. It is true for many people. And what then happens is we often lose them because they don't even come back to find out. Or if they do find out and you're not there to talk with them about what the next step is, or be able to have an opportunity to ask the doctor, what does that mean and what are my treatment choices? Again, people often are traveling distances, can't get back to talk again, or there's a long time, maybe in the winter, so on. So again, I'm saying that this is something you really have to really get much more involved with and be able to bring it, down to, I call it to my level, to a level where people really understand it and have easier access, to this kind of resource. Without any question, it certainly can more than just help. It can totally reach so many more people and get back to follow-up, which is a real critical area, particularly with cancer, because people not being able to come back regularly or talk about their symptoms and problems they're having with treatment. I think this is terrific.
It really gives us, I think, an opportunity to be very creative, that the education that emerges does not all have to be MD focused. A lot of the work that we've done in southern Arizona has been around working with community health workers and really setting up uniform curricula in different cancer areas that then they are able to go out and do the network. They can reach more people more effectively that way. That might be a model that would be exportable with your community health workers. Doing work with nurses. Nurses, I think, do a lot of patient education. We're developing several grants with pharmacy. Pharmacists, there's so much polypharmacy out there, and we know that after 5 medications, your chance of having a reaction is really high. We know for certainly the elderly, folks over the age of 50, 55, 60, which I guess is not so elderly really, but when we look at folks that take medicine, there's a lot of risk, and to engage pharmacists in more of that education piece, and that if you have somebody that has the time, that has the interest to really work with people to help them understand a lot of these issues, I think it's a tremendous service. Not only a service, but I think certainly from a pharmacist standpoint, from the standpoint of cancer screening, there's so many of the topics that we've discussed. These are interventions that will save lives. So very significant. And I think we can work together to design these, implement these, and then look at the outcomes data.
Very exciting.
Yeah, Dr. Lopez, my name is Peter Nez. We've got a program that we work out of the Black Hills Center for American Indian Health called the Southwest Navajo Tobacco Education Prevention Project. And we've been working with the Navajo Nation for the last 4 years. We got a 5-year grant with CDC, and the program that you're talking about, taking this thing out to the communities really intrigues me because of the fact that, we're a community-based organization. And I'm just kind of trying to figure out, I know that, the networking is kind of unique because at one time we were even thinking about utilizing our prevention program based on the same type of networking that you have here. We were wanting to, there's an organization that came out and, introduced themselves and trying to sell us this product, and it's all, it's basically the same thing. And, it's almost like doing prevention education out in the community and tying in communities, hopefully tying in the whole Navajo Nation. at one time and being able to carry on prevention education like this, you know, and, you know, there's even a talk about, you know, bringing the education into the whole gun, you know, through one of the programs that is coming out of New Mexico. And it's basically the same thing, and I see it unique, you know, I really, I'm just so, I like the, you know, the concept, but, you know, as far as getting the people at the community, because more or less, prevention education comes from the home, you know, it doesn't, more or less, it's when they get to the hospital that it's more or less, you either have it or not, you know, if you feel the pain, you go to the in-and hospital. If not, you know, majority of the people are still out there not being able to get their proper diagnostics, you know, so in a sense, you know, I cannot see this thing really working, you know, unless you can convince me. I don't see this really working with the community out in the remote area of the reservation due to the fact that, you know, you still don't get the doctors or the person that is there providing the services that is uniquely needed out in Navajo country. Unless you have a doctor going out there or somebody that is specialized, the individual still has to come into the hospital and being able to have a conversation with you like this. I'm just kind of, I know that, you know, at the community level, you know, you've got a coordinator there that, you know, is more or less in charge of the computers. You know, even if you want to have utilize the computer, you more or less have somebody that is in charge of, you know, how the computer is being utilized. I'm just kind of trying to figure out, you know, how an individual that has been diagnosed with cancer and, you know, be able to get the services that they really truly need and still not be able to get to the hospital.
You know, that's a very powerful question, and I think certainly telemedicine cannot resolve all of the healthcare delivery problems that we have today. That's not the solution for everything. However, if we just take some examples, and we'll focus on cancer, although the applications, I think, go well beyond cancer. In the field, and I would say that this is true in the field of prevention, diagnosis, and treatment. For example, in the field of prevention, there are units that the community health worker made. They're very portable. They're suitcase units. I thought about this after we confirmed this conference, actually, that I could have done this from my office because I have a portable unit on my desk. And that really is, if I travel, I can take that unit with me and I can be connected through either a phone line or a broadband internet line to anywhere in the world and do this sort of video conferencing. So this is a suitcase system that a community health worker could have with him or her as they go along visiting patients, doing their patient education, connecting their patient perhaps to the nutritionist at the hospital, connecting their patient to the cardiologist if the system has a stethoscope attachment, so that they could be assessed for their toxicity therapy. We could look at the patient's mouth to evaluate for mucositis, could do vital signs. So there definitely are systems that are available, that are portable, that could be used in the home for education, for monitoring of patients' side effects as related to cancer chemotherapy. As far as diagnosis, as we've discussed, the patient may need to go, clearly there's not portable mammography where you can do your mammography at home, but where the patient can go to a central area, have the reads done elsewhere, where the patient can with even if on-site telepathology